was actually a lecture that Dr. Austin Eggers put together, and then of course he decided he wanted to live closer to home, so he's practicing up in the Madison, South Dakota area. If you recall, he was with us in the clinic for a while. He put this together, but we've got permission from him to go through this. So today we'll be talking about advanced directives. I kind of feel like a lot of people, who doesn't know what advanced directives means? Maybe a couple, okay. Because we talk about it a lot, and now it's been incorporated into some of the screening things that Medicare wants us to do. And so most of us have been asked questions about it, but there may be a few things about it that we may want to cover a little bit, because there are some things I think sometimes we don't think about when we think about advanced directives. But what is advanced directives? Advanced directives is not a result of the death panels. Remember, this is several years ago when Barack Obama was president, and they were talking about more of an effort to 20% of the healthcare dollar is spent in the last 10 days of life. Okay? And a lot of it is because we do a lot of futile treatments, as we'll get into a little bit, for things that aren't going to make any difference on the outcomes. We spend a lot of money and resources on things that may not make much difference. And so there was an effort to say, okay, how can we curtail some of these supposedly unnecessary expenses? And so there was a strategy to kind of look at, okay, how can we do this and still maintain people's rights and still keep the philosophy that came from common law back in England and that sort of thing. And so there was a lot of editorializing about death panels. So that's really not what we're talking about. And a lot of people get suspicious when we talk about advanced directives. And I think it's a barrier for some people because they think of this right away, that we get a certain age or a certain condition that we don't want to spend any money on you anymore. That's not really what it is. Advanced directives are not just for those of us who are over age 65, all right? Advanced directives are for anyone actually over the age of 18. So what is it? Advanced directive is basically a written document that is prepared before, and advance means, of course, before or ahead of. So before you need it, okay? It's kind of like car insurance. You know, you have it, hope you don't use it, but it's prepared in advance, and it's usually before any life-threatening event or chronic illness that is going to render you unable to make decisions on your own, okay? And what this document does then is expresses your preferences, your wishes, your desires, and your values for how you want to be treated if you are unable to communicate or let us know what your preferences are. You know, for example, if you develop appendicitis and we have you see the surgeon, we're not going to cut you open until we have your consent. All right? We need consent. If we do that without your consent, somebody's going to put handcuffs on us and we're going to go to jail for assault if you decide to press charges or anybody presses charges. Because to do that there's a legal term, and I'm not an attorney, okay? And I didn't sleep in a Holiday Inn last night. But there's something that's called unprivileged touching, all right? We have a right to our own space. We have a right to not be victimized. And so if somebody does something to us to injure us, that surgery is an injury, it's a controlled injury, but we need consent, all right? Now we take the same person who, let's say, is in a car accident, and if we don't know anything about, there are laws that protect doctors and healthcare people from rendering care in a situation where we may not be able to get consent, okay? If the ambulance gets called out on Highway 60 and there's a bad crash and people are unconscious, we don't know who they are, where they are, whatever, we're going to assume that we're going to do everything for them until we otherwise learn that they either didn't want something done or activity is going to be futile. So we need to have consent in most cases, and so we are always in those situations where we don't know anything or have no one to talk to and get no direction. We are going to assume that we're going to do everything. Maybe that person we do everything for doesn't want everything done. It's not consistent with their wishes. There may be something in their medical history that we don't know. There may be a desire for them not to have any certain types of treatment. And we talk about values as well. For example, there are certain faith groups in this country who don't want blood transfusions or don't want products that are derived from any animals, which puts insulin in curious perspective, but we do have human insulin now, so that's a little bit different. But so we have preferences, faith-based preferences, and that sort of thing. So when we talk about advanced directives, we basically talk about two documents, mostly, okay? The first is a living will. The living will is a written document that has a certain legal standing. Now, it doesn't have to be put together by an attorney. However, attorneys do that. My lovely bride and I, ours are done by an attorney. We just did that when we did estate planning, and so the attorney did it for us. But you don't have to. There are forms that you can get. They're available. You can print them online. But basically, it's a form that you sign. Generally, it needs to be witnessed, or it needs to be notarized, that sort of thing. And so that and then of course it needs to be communicated. And that's a big aspect sometimes where we see a gap there. The other document we talk about is durable power of attorney for health care. Okay? So this is a durable power of attorney. Of course, durable means adjustable or changeable, and so this is the kind of thing where you designate generally a family member, maybe a good friend, trust officer, someone who is able to make decisions for you if you are unable to. Big caveat here, because I get that a lot where somebody calls, I know my mom was in the clinic yesterday, and I want to know, I'm her power of attorney, and I want to know why she went in yesterday. Are you listed on a HIPAA document? No. Then we really can't tell you. But I'm a power of attorney. Power of attorney doesn't come into effect unless mom is unable to make her own decisions. You have to be there has to be documentation that you are incompetent before that durable power of attorney healthcare takes effect. Okay? So somebody may indeed be your power of attorney, but if you don't have them listed on the HIPAA form, nobody's going to talk to them, and they're not going to have the ability to make any decisions. Unless or until the person that executed that durable power of attorney is not able to make their own healthcare decisions. Okay? So you may be a power of attorney, but that doesn't give you the right to do anything unless the person that you're the attorney for is incoherent or can't make decisions, is in a coma, etc. Living well involves life-sustaining treatments that you want or don't want in life-threatening situations. When you look at the history of living wills, really, none of this came into play until about the 1970s. Because the decade of the 1970s was really when there were a lot of advances in resuscitation, heart care. I mean, if you watch reruns of Gunsmoke, Doc Adams never worried about this kind of stuff, right? If Matt Dillon shot you, you were pretty much, that was it, right? You know, so if Matt got shot and was laying there unconscious, nobody, you know, there was not a lot Doc could do back in the 1800s in Dodge City, Kansas, okay? And so these things really didn't start up until about the 1970s. So there's been kind of an evolution of how these documents affect what we do. They have different roles in different states because they mean different things in different states. In the state of Iowa, if you have a living will that says, I don't want to put down and be brief, or I don't want CPR or anything like that, if you become unconscious and can't communicate, your durable power of attorney for health care can void that. That living will is only an expression of your wishes, okay? That's why it's very important that when you execute a living will, or you put a living will together and a durable part, you gotta let somebody know, okay? When we had ours done, there were big thick envelopes, and we gave, okay, we want this daughter to make decisions about this, we want this daughter to make decisions about that, we want this daughter to make, we let them know who was gonna be in charge of that. You've gotta communicate. If you've got a living will, and if you don't have, if the person who is going to be making your decisions for you, or if you make a living will, but you don't have a durable power of attorney for health care, it kind of makes that living will a little limited. It's usually a good idea to get a copy over to your medical provider's office, the hospital, the community you live in. Most states in this part of the country will honor living wills from other states. They will honor those, okay? In preparation for this, I know Texas will accept Iowa. There are some other southern states that will. Not surprisingly, California and New York, they have to have their own, they don't call it a durable power of healthcare, they call it healthcare surrogate or something like that, and you have to have that. So it's usually a good idea, if you're gonna spend a lot of time in another state other than Iowa, find out, number one, if their state will generally accept a living will from Iowa if you've already got one. Or if they don't, it may not be a bad idea if you're spending 6 months of the year down in, say, in Arizona or whatever, to just verify down there, is this valid down, is an Iowa living will valid down in Arizona, okay? And all the states maybe you have to travel through to get there if you go by car, all right? But what a living will does, it lets the people taking care of you, and generally it's healthcare workers, doctors, nurses, therapists, everybody, family, friends, know what your preferences are for medical treatment. And that again brings up the big C word, communication. You gotta communicate what you've decided, okay? The durable power of attorney for healthcare is where you, generally there will be one person you designate. You may designate another person as an alternate, or if that person is not available. But basically they make your medical decisions if you are unable to, okay? If you're otherwise fairly healthy, but you have some sort of illness or whatever, and you're able to communicate, that does not take place. If your condition deteriorates, or you become unable to make your own decisions or communicate your own decisions, that's when this person steps into that role, okay? When we are competent, we are basically our own attorneys, let's say, okay? And I'm not talking about an attorney at law. Those are the people that have to go to school, get a diploma, and they have to know something, all right? But for most of what we are our own attorneys. And so what this does is it appoints, it's called attorney of fact. We're making our own decisions, we're doing our own thing, but when we are unable to, we need to have a different attorney in fact. Not attorney at law, attorney in fact. That's a person. And so this designates an attorney in fact, all right? Generally, if you have adult children, generally it's usually an adult child. We are seeing a lot though with broken families and different things. A lot of adult children don't get along with their adult parents, okay? Certainly if you're married, it's generally a spouse. It can be other people, it can be a good friend, but it has to be someone who is deemed fairly objective, okay? So it can't be, for example, if I'm taking care of you, you can't designate me as your durable power attorney for healthcare. That would be considered a conflict of interest, okay? All right? I can make decisions about which antibiotic to use. I can make decisions about, you know, what kind of therapy you might need or that sort of thing. But I cannot decide for you whether or not, if you've got a chronic condition, that we're going to do CPR or put a tube down your throat or whatever to breathe for you, okay? So anybody who's providing you medical care is not really allowed to do that, okay? And it cannot be an employee of your treating healthcare, so any of the employees of the hospital necessarily, or of the clinic around here. If you doctor here, if you doctor somewhere else, can't be someone who works there, okay? Unless they are your family members. So if your daughter happens to be a nurse and works at the clinic, yes, she can be your durable power attorney for healthcare, okay? Third degree consent, it's like the second and third removed, okay? So your first order is your spouse or sibling. Okay. Second order is, I think, parents, grandparents, and children. And then third is like nephews and nieces, that sort of thing. Right? There's a whole chart on that sort of thing. You deal with that, the insurance stuff too, the second, third degree. So, but that just tells how closely related there are. Okay? Can I change my mind? Yes. As long as you are of sound mind and body, you can change your paper and execute a new one. That no matter your mental or physical condition is really not true, because you have to be competent mentally to change it. Like changing a will or anything, you have to be able to make those decisions. And again, that needs to be communicated. It needs to be communicated to the new person you've designated. It needs to be communicated to whomever's going to take care of you. All right? Any questions so far? Okay? All right. If it's a legal document, it is considered a legal document. Do I need a lawyer? No. Not in the state of Iowa, you don't. There are standard forms, and there's a lot of leeway, and it's purposely meant to be a little bit vague, because you can't predict every situation, okay? But as far as I know, if you choose the Iowa Bar Association form, that has to be, you have to go to an attorney, okay? Attorneys are good for this. They do a very good job with it, and this is, doing this for attorneys like Dr. Treat Strep Throat. You do that in your sleep, but you don't need that. But and there are resources and forms. In fact, I think we've generally had forms that you can use here at the hospital or at the clinic, and there's a lot of different kinds. You can print them online that are good for most states. Okay. And it can be very vague, or you can add more specific instructions if you would like. But generally, again, it has to be witnessed or notarized, okay? Our advanced directives always follow. Like say, the state of Iowa, that the answer is no, because we may have certain circumstances whereby, let's say, for example, if you're painting the peak in your barn and you fall off your ladder, and you have a head bleed and you're unconscious for 3 days, but you were otherwise healthy before that, that would not necessarily meet the definition of a chronic illness. And you might be unconscious for a week, but you have the potential to totally recover. So in that situation, it doesn't necessarily apply, and that's why these forms are kind of vague, because it gives us some leeway to help maybe save your life, but yet not be causing undignified treatments if you have a terminal illness, okay? So it's legally recognized, but not legally binding. Yes, you can, again, in the state of Iowa at least, and I like to stay with the state of Iowa because that's what I'm most familiar with. Again, it's an expression of your wishes. And your durable power of attorney can elect to not totally go with all your wishes, or any of them for that matter, okay? Let's say, for example, you do have a chronic illness and you're deteriorating. Your son is serving in the military in the Middle East, and it's going to take 2 weeks for them to get home. And your durable power of attorney says, we've got to keep Dad alive until my brother Joe gets here from Iraq or whatever. Okay? We've seen this a lot. So sometimes they'll say, nope, do everything. I want you to do everything possible for Dad until Joe walks in that door. And then we can go from there. So again, it allows for some leeway for those situations. Okay? And again, the forms are vague, and that's on purpose, okay? We would hope that your relationship with your durable power of attorney is good enough, and you've communicated, of course it'll say on the form, give guidelines, that you sign on what kind of treatment you want. But your attorney should follow your wishes for what they think you would want to have done and how aggressive you want your treatment to be. So, basically, if you're unable to make your decisions, they're the ones making your decisions for you, okay? If we have no guidance, if the medical people taking care of you have no guidance, we're gonna go ahead and we're gonna pull out all the stops and do everything we can for you, all right? And so and some of that may be futile, but if we don't, we have legal ramifications against us if something would happen. So if we don't have guidelines, we're gonna pull out all the stops. You'll have tubes coming out everywhere else. You'll have machines and beepers going off all day long. You may not know a week from Tuesday, but that's what's going to happen. So, and that's what we're trying to be judicious about, because as we've gotten used to all those technologies that came about during the 1970s and have gotten a little bit more effective and a lot more expensive, I think a lot of times, especially those of us in the rural area who understand mortality, and we understand that we're not going to be on this earth forever. There's going to come a time when we're going to be leaving these temporary bodies behind. And so because of that realization, I think we see a little bit more balance on people saying, you know, if that happens to me, I really don't want that done to me or for me or to me. Just let things take their course. So what does that entail? What do we do? Life-saving measures. Well, basically the first thing we think about and do that is we do CPR, which is cardiopulmonary resuscitation. So this is the BLS and all the, 1,000, 2, Annie, are you awake, etc. And if your heart stops beating, we're going to start pumping on your chest to get blood moving until we can do something more definitively. So that's one of the first things we do to try to bring you back, all right? The other thing we will do is if you are unconscious or if your heart stops, and when your heart stops, you won't breathe on your own. Sometimes you will stop breathing before your heart stops. So we got to breathe for you. It's much more effective to have a tube down so that nothing obstructs things, to be able to breathe for you. That's what we do during surgery, while we're doing a lot of surgeries, all right? And that's a machine, it helps you breathe. And that machine's not gonna stop unless we turn it off, all right? Hospitalization. There are situations where when we have somebody, especially with a chronic illness, or somebody that's very debilitated, that we know that eventually this person's gonna probably get pneumonia and that's what's gonna take them. Or if they've had a major stroke and they're not responsive, until they get weak and their heart stops, all right? Dehydration's not a bad way to go. We know that dehydration will decrease your pain response and make you more comfortable, okay? So sometimes if you're in a facility or whatever, we will write orders, do not hospital, do not transfer, do not hospitalize, okay? And then of course, out of hospital non-resuscitation, that's just, that's so that we don't get this whole process started, okay? I've been in situations where, this was years ago, I was a medical director of a nursing home and somebody had advanced directives and there was some turnover in the nursing staff and they didn't all realize what was, this wasn't my patient, but I was the medical director. So what happened is we had a patient who had a living will, did not want to be intubated or transferred to the hospital, and the family didn't want it either. And what happened is, I think she choked on a lifesaver or something like that, and passed out, heart stopped, CPR, everything, a whole ball of wax. She got taken to a hospital, and of course my phone started ringing, because I was the medical director. And so we had to definitely do some retraining to make sure that the staff knew of the person's preferences, okay? Because the person did end up dying, and now family's got a big medical bill that they were trying to avoid, okay? We have another, this is really not an advanced directive so much, it's kind of in that, it's called a POLST, known as Physician's Orders for Life Saving Treatment. This is what we will fill out in response to your wishes. It's a special form, State of Iowa has a special form, and a lot of times, usually where we'll get it from is a nursing home or somebody's on hospice. And basically, it's similar to an advanced directive, but it's actually the doctor's orders that say, I don't want to be intubated, I don't want CPR, if my heart stops, let me go. This is a form that your doctor or provider will fill out so that the staff has orders not to do those things, okay? And there is a section on feeding tubes and that sort of thing as well. It's a special form, so if you ever come across what's called a POLST, POLST is used kind of in all 50 states. Before we had the POLST, we had, I don't know if we still have the iPost or not, but that was an Iowa form that was specific for this sort of thing for the state of Iowa. Most states have gotten rid of their own, and there's a universal form for that now. And then there's a place where the patient or the durable power attorney healthcare signs, and then the doctor's orders go on that. So that actually, the POLST should reflect your wishes. Okay? So, if you haven't done it already, when should I think about doing advanced directives? Anytime. Earlier is better. It's not only meant for the elderly, also for young adults, anybody over age 18, okay? Anything can happen. We live in a dangerous world. My wife and I don't go to Sioux Falls on weekends anymore. Take your life in your own hands. But there's a lot of things, you know, automobile accidents, other trauma at home, falling down some stairs, that sort of thing. I mean, you could have a situation where that happens, and if the situation is reversible or potentially reversible, that's one thing. But if you have a permanent injury and you don't have this, you may, and I've seen conflicts amongst families because mom or dad did not have something there. This daughter wanted everything done. These two, the brother and the other daughter, don't want any heroic stuff done, and now you've got a fight. That was probably unnecessary if mom and dad would have taken care of this. Okay? And basically, talk with your physician, talk to your provider. If you do execute again, copy to whoever, relatives, people who are going to be making decisions for you, make sure they know. You've got to communicate your, wishes and make sure that everybody knows, okay? And again, advanced care planning is covered by Medicare. It's part of the annual Medicare visit, so that's why, trust me, if one of our nurses asks you, if you stop breathing, do you want us to put a tube down your throat? Doesn't mean we think you're gonna die in the next 5 minutes, okay? That's a question we ask everybody, all right? I asked the patient, before we did the Medicare annual visit, I asked the patient that, and she burst into tears. She thought that she had terminal cancer, and I hadn't told her that. I thought I was preparing her for, No, if we ask you these things, we want you to be thinking about it ahead. It doesn't mean we think something's gonna happen in the next 5 minutes, okay? So, the good time to decide about this is before you have an emergency, before you need it, okay? Because a lot of times if there's an emergency, especially, if you had a chronic illness or terminal cancer, a lot of times the family has time to cope and adjust and understand what's going on. If you have an injury or a sudden event, there's a lot of emotions, and there are a lot of bad decisions that can be made when there's a lot of emotions, okay? So do these things before an emergency happens. Will I make it? We don't know if you come in, especially in an emergency situation. If people come in, we don't know sometimes if you're gonna make it or not, but we know if we don't do anything, you're not gonna make it, because you might recover. So we're gonna do as much as we can to ensure your recovery. Now, if 3 to 5 to 7 days later or whatever it is, it looks like, ooh, you're not recovering at all, then we may have to reassess what we're doing, and then that's where the advanced directives come place. Now we're looking at a condition that's probably not reversible. Now you start falling into that category. You got a permanent injury that you're not gonna recover from. We didn't know that when you came in, but we know that now. After things kind of declare themselves clinically, now we've got a basis. Now you're kind of falling into that terminal cancer kind of party, So we're still in certain situations, the medical community is probably going to push for, hey, let's do this at least, and then see if we get a good response and dad recovers, fine. If we don't see much changing in 3 to 5 days or whatever we do, whatever we expect, we're not meeting expectations or recovering, then we can invoke the living will type things. Just a few statistics, and I think these are good. CPR. Talk about CPR. Back in 2015, they had a bunch of medical people watch a bunch of TV shows. Okay. If you are on a TV show and somebody does CPR on you, on the TV script, you got a 70% chance of surviving. We survey the general public, and the general public thinks if we start pounding on your chest because your heart stops, you got a 75% chance of recovery. Well, let me tell you something. That's not real life, okay? Many studies, and one of the first studies came out of the Lancet in the late 1960s. The survival of out-of-hospital cardiac arrest was 7.6%. Okay? So if you're walking down the street, just had your hair cut, and you decide you're going to go over to the lantern and you fall and collapse, and somebody sees you do that, in the best case scenario, somebody starts CPR right away within the first few minutes, your chances may go up to about 10%. There was a study in Seattle that showed about 10%, okay? Big study in Sweden showed that despite all of our advances, that if your rate of survival in the 1970s was 6.7%, but in the 90s it's only 2.4%. Okay? Why do you think that might be? You think, well, we got all this technology here. Joe's walking down the street, he collapses, somebody starts CPR, calls 911, he gets all the best treatment. He's got less chance surviving in the 90s than he did in the 70s. What do you think that is?
People don't care.
We're not as healthy as we used to be.
We're older and we're sicker. Okay? COVID showed us that. Okay? Especially in the United States, we're not very healthy. Plus, a lot of us are walking around with more chronic conditions. Okay? There's a lot more people alive, say, with COPD, chronic kidney disease, advanced diabetes, stuff like that, than there were in the 70s, because a lot of those people died before their heart would stop. They died of something else. Now we're keeping people more functional longer with more chronic diseases because of our better treatments for diabetes and a lot of the stuff we treat. So the chances are, if your heart does stop, it's for a reason that you're less likely to recover from. Okay? And this takes me back to a study in the Lancet that was in the 80s when I was in medical school. There was a study in the Lancet, which is one of the biggest medical journals in Britain. And they said if your heart stops because of a heart attack or because of primary cardiac problem, your chances of resuscitation were about 8 to 10% if you started CPR. If you've got advanced cancer, advanced heart disease, advanced lung disease, or liver disease, you had only about a 1 or 2% chance of being surviving a cardiac arrest. So if your heart stops because of a heart problem, your chances are actually better. Okay? CPR, fractured ribs. How many ribs do you think I broke? Julie?
A few.
Yeah. I'm an old farm boy who used to throw bales around and lifted weights when I was in high school and college. So yeah, I multiple broken ribs. But for a long time with CPR, we've been trained that if you break a rib, the CPR is going to be more effective. So don't worry about breaking ribs. About the third punch, you hear a bunch of crunching, and so if the patient does survive, they got multiple rib fractures, which cause you to not breathe real deep, and then you get pneumonia afterwards. Okay? You've got about a 60% chance, maybe a little higher, 70% chance of, if you're over age 65, some studies over age 59, some studies put the cutoff at 65, some of them put them at 59, all right? I think 65 is the new 30 myself, but that's just my own personal bias. But if you survive CPR, you're going to take a hit on your brain. You are much less likely to function independently. So even if we bring you back, we don't bring all of you back. We leave some neurons behind, we leave some brain damage behind, probably some other end organ damage behind, okay? Especially if you don't, because 3 to 4 minutes, the brain is going to start collapsing. The dominoes are falling fast in the brain after that, okay? In fact, if you don't start CPR by 10 minutes out on the field, your chance of recovery is basically 0. So, if you get real aggressive, you can lacerate the liver and spleen with CPR, collapse the lung, other internal bleedings. Yeah, there are things, those are side effects. Okay? Intubation, that's if you don't breathe on your own, stick a tube down your throat. There's a link to a video that shows somebody getting intubated. I don't know if he put that in. I don't, is this a touch screen? No. Okay. We'll maybe pass that. Okay, and the other thing, knock on wood, I don't think I ever broke a tooth, but it's very common to have teeth broken when you open up, because we have a instrumentation that opens up so we can see what we're doing. You can always damage the vocal cords. That's a side effect. If you haven't damaged vocal cords intubating somebody, you just haven't put enough tubes down yet, because that will happen. throat pain afterwards. Aspiration, when we bypass your own protective mechanism, is possible stomach contents, if you vomit, so that's a lot of times if we put a tube to breathe down, we'll also put a tube down to your stomach to decompress your stomach. But another reason to intubate is somebody who's in a coma, because if you're in a coma, you can't protect your airway, so you're better off with a tube in than not, all right? Pressure from the ventilator can blow your lungs, just like overinflating a tire. Could pop your lungs and collapse both lungs then. If you've got sensitive airways, it can cause asthma-like condition, which is tough to treat. If we give you too much oxygen, we can wreck some things in your body. So, spinal cord injury, especially in motor vehicle accidents, is a big thing. Okay? Basically, the takeaways from the CPR and the intubation is CPR is not as successful as you might think about on TV. Okay? Doesn't mean we don't try, but if you have a chronic illness, that makes it more likely for your heart to stop. I mean, you know, when we get fill-out cause death certificates all the time, all right? There's a tendency for some doctors when you're first in practice to put cardiac arrest. Well, guess what? Everybody who dies, their heart stops, okay? So what causes or what set into motion the course of events that caused their heart to stop, okay? Was it a heart attack? Okay, then it's a myocardial infarction, okay? Is it an injury? So it's trauma. So basically, when your heart stops, there are conditions that are in your body that cause your heart to stop. Okay, and doing CPR, we can, if they're reversible, but we don't know if they're reversible. But again, if you've got terminal cancer, and if you don't have an advanced directive, if your heart stops with terminal cancer, chances are we're going to call 911 and everybody's going to do everything. You know, we're going to do all these things to you, which won't make any difference. Okay, that's why we talk about advanced directives. Okay. Yeah. Low percentage of people survive, lower than what you see on TV, and if you do survive, you won't be unchanged. Okay? And almost everybody, if you had good CPR done, if it was effective CPR, you're probably going to have some sort of injury. Okay? So what do we do from this talk? Okay? If you haven't done advanced directives, talk with the doctor, anybody at the clinic. We've got people, there are people here at the hospital that are trained to talk to you about this if you have questions. I don't know if we have forms here today, but there are forms available, okay? In this digital age, we a lot of times don't print out stuff and have, because these forms change from time to time, so what we would do is just go online and print one out for you if you needed one, okay? But communicate. Let your loved ones know, anybody who's going to take care of you know, or potentially make decisions, make sure they know about it, okay? There are a lot of different mechanisms or outlines we use. There's one thing that we're talking about more and more, it's something called the 5 wishes. And the thing you have to ask yourself, this is my wish. Does anybody know these are my 5 wishes? Okay, the number 1 wish is who? Who's going to take care of me? Who's going to make my decisions if I'm not able to? Okay? Number 2 is my wishes. What do I want? Do I want CPR and everything? Do I want to be intubated? Do I want to feed tube? Do I want doctors, nurses, and everybody to pull out all the stops? If I have an untreatable condition or terminal cancer or chronic condition, then I'm probably not going to survive anyway. What are my wishes? Okay? The next wish is, how comfortable do I want to be? Okay? What do we do for comfort measures? We give pain medicines. There's a lot of things we can do nowadays. And we've got better things now even than we did 5-6 years ago. So express how comfortable you want to be or how you want to be kept comfortable, okay? The next wish is, how do I want people to treat me, okay? Because the important thing is, when we talk about, say, not doing CPR, not intubating, not doing heroic treatment for somebody, say, with terminal cancer or a chronic illness, it's basically to help protect that person's dignity. Because a lot of stuff we do in medicine is not very dignified, okay? I know that because I tell men to pull their pants or bend over, and I put a glove on, half of them are screaming before I even get my finger doing a business here, okay? A lot of stuff we do in medicine is not very dignified. And so, you know, we lay in bed pretty soon, before you know it, so we don't know what this person's output is, we got to intubate, oh gee, we better put a catheter in so we know how much fluid to give them. And so pretty soon you got a tube coming out of every orifice you could think of. And it's just, a lot of it has to do with dignity. And understanding what your wishes are. How do I want people to treat me? And then the last one is, what do I want my loved ones to know? Okay? Again, that goes to the communication, telling you the people who are going to be making decisions under your advanced directives, letting them know. And then also, because of, thank you, President Clinton, the HIPAA thing, which I think was right, because there was a lot of hanky-panky going on with people's protected health information, is make sure that you let us know who in your family we can talk to about your health condition if they contact us, because sometimes things will happen and we're stuck. Now there are sometimes you can make exceptions in certain situations, okay? But it's good to have that list, and I think that's covered a lot of times in some of the screenings and stuff we do as well. Any other questions? Yes?
You're talking about that CPR and breaking ribs and stuff. So do you have a better chance if you get an AED machine? That's after that instead of somebody having CPR?
Well, CPR and an AED are not the same.
So, but
An
like,
AED is only going to give you a shock if you have a shockable rhythm. Not all heart rhythms are shockable.
oh, so
Okay?
that
If your heart totally stops,
okay,
we put a flat line on you, that's not a shockable rhythm. Shocking your heart ain't going to bring you back.
really? Okay.
That a shock would not be advised.
Oh,
Okay? If you had VTAC or VFib, that's a shockable rhythm. And if you look at all the boxes around town where there's an AED in there, that's only to give you a shock. And the reason we have those is because when we look at some of the most common rhythms people die from, VTAC and VFib are pretty high on the list. And if you look at some of the research that we have with resuscitation, if you have a shockable rhythm, early defibrillation could be the magic bullet that can bring you back. Okay? But CPR is basically massaging the heart to keep blood pumping, but it's only about 20% of what your heart would normally beat anyway. So it's not a good substitute for a heartbeat. It's just a stopgap measure until we get your heart going again. That's why if somebody comes in and they say the ambulance is doing CPR, now there's something called the Lucas device that a lot of the ambulances have now. It's a mechanical plunger that works on compressed air that does the compressions for you. And basically what that does, it frees up another rescuer. And I tell you what, CPR is hard work. You got to, and so you switch off in those situations. It helps prevent rescuer fatigue, and it frees up a rescuer. It's like having an extra person there. But a Lucas device, you're going to get just as much trauma, because a Lucas device is going to have a preset based on adult or child or whatever. The depth of for an adult, you got to go down about 2 inches. Okay? If you have somebody pushed out, that Lucas device is going to go down about 2 inches on an adult. And that's what we should do if we're doing effective CPR, should be 2 inches for an adult. That's going to be the same amount of trauma. But the AED is different than CPR. CPR is just to kind of hopefully keep your blood flowing and keep some oxygen going to the organs. In the old days, we would always do breaths with that as well. Nowadays, you do several cycles of CPR without any breathing, because when you're doing CPR, you are changing some pressure in the chest, and a little bit of air is going in and out. Not something that's going to keep somebody alive for a long time, but initially, that's again a stopgap measure until we can get something definitive. Okay? If your tire goes flat and you go in your trunk and you see this little donut dealing in the back of your car, you can put that on and go, what, about 40 miles? But that's not a real tire. That'll get you to the next air pump station or whatever, probably, but it's not the real deal. And that's kind of like CPR. It's a substitute, and maybe not a very good substitute, but it's all we got.
You were talking about some states not recognizing our Iowa, how about South Dakota? Because a lot of times we're headed there.
Again, I don't know every state, but most of the upper Midwest states will recognize the border states generally, yes. I think most of the time, I'm not aware of any situations where we've had people that we've had to send to Sioux Falls where the Advanced Directives got activated. I'm not aware of any situations where South Dakota has said, no, it has to be redone, or you have to fill out this other form. They're pretty much going to recognize it, I think. Yes.
If you end up in Sioux Falls, is our stuff shareable with them, that if you ended up in Avera or Sanford or, you know, a different...
Well, if you end up in Avera, it's going to be there, because because what we will do is that form, we will scan it into your chart. And so our chart's the same. Sanford, no, we have to scan that or send it along with, but sometimes we'll send it with the ambulance or whatever, yes.
So you would send it along, it isn't something...
And it may be an oversight if somebody doesn't think of it, but on some protocols, there's a little check mark for it.
Okay,
And so, yes, we might, yeah.
thank you.
I'd just like to share a couple of human interest stories. I'm a retired nurse and did CPR on a patient in the hospital, so we had access at the very first of when CPR was instituted. The man survived and came back to tell us later that, I think he was from Omaha or something, that he lived like 9 months and he had time to get his house in order. And he thanked our hospital for having me, the doctors and nurses trained in that, and that was very good for me as a new nurse, to a young nurse, to have successfully allowed this person to do that. But since then, I've been in nursing 40 years, and with my career and EMT, and since that I have not, I've seen people survive, but like you say, there's been broken ribs, there's been things that have made it not quite as good. I don't know if you call it a blessing in disguise, because my first husband passed away when he was 43 of complications from leukemia. He was in Avera, and they came to me by myself. I had 4 young kids, and he had family, and asked me what John wanted done, because he was near death, and or getting close, and it was up to me to decide. But thank goodness John had told me. We went by a lady on all kinds of tubes, and he said, "Don't you ever do that to me."
So at least it was communicated.
It was communicated. So I would say everybody's situation is different, but now try to tell 4 kids who are now old, they're getting old, they were, and that I want to talk about my death, you know. Well, it's taken me probably the last, since I was diagnosed with breast cancer, the last 4 years. It's good, it's nice, because it was caught early, but I've been trying to tell my kids, you know, I'm not going to live forever. And now I'm 80. They have to listen to me. They have to listen to me. We don't want you to die. Well, it's 4 years.
Yeah, don't always get what we want.
So, just keep that in mind, communication.
And that's the thing, everybody's situation is different, it's not a cookie cutter approach. It reminds me, I like to go fishing once in a while, this guy went out, he was gonna go fishing, so he goes out on this dock, and there's a guy fishing on the other end of the dock, so he goes, well, I'll go on this side, and he's fishing, and he's looking, and this guy over there is catching a fish, he catches this huge fish, he takes it off the hook, he looks at it, throws it back. About 3 minutes later, he catches a little fish, about 6 inches long, he keeps it, he puts it on a stringer. A little while later, guy catches another big fish, throws it back. Catches a little fish, puts it on a stringer. Finally, he couldn't take it anymore. He walks over to that first fisherman and he says, I can't help but notice that you're fishing here. You're throwing away those big fish and you're keeping all the little ones. The guy says, yeah. He says, I plan on frying them up for supper tonight, and I only have a 6-inch fry pan. So we don't always know what size pan somebody else has, right? So sometimes we think we have all the answers for everybody, and everybody's situation is different. Okay? All right. Yes?
So I don't know even where I got the form, I haven't filled it out, but it was a whole page. And it says, if this happens, I want in, it was, I think you had a choice of 3 different things, and like, if I'm on a feeding tube or something, I can't remember, and I haven't filled it out. Is there anything like that where it has more specific things?
Yes, there are forms that already have those. There are forms that have areas where you can add those if you want to. And that brings up a very good point. Thanks for reminding me. If you say, yeah, I did this 20 years ago, I did this all, so it's all cooked and fried. I mean, you know what? You may want to look at it again because situations change. You know, the person that you had named may no longer be with us. The person that you thought was going to do it now may have some problems of their own, and they really can't be called upon in your situation. So it's a good idea to maybe pull them and review them from time to time. Mine's changed. We've had them redone. You know, it's different when the kids are older, and that sort of thing. You know, don't want to do this when they're teenagers, because when they're teenagers, they know everything. Sounds like your kids may still know everything. But yeah, it's a good idea to look at that. And if you've got any questions, you know, talk to somebody about that. Can always, you know, you can call a clinic, wherever you have a copy of that, you can say, could somebody just review that and see, is it a suggestion to make any changes on that, you know? Some people's spouse dies, they get remarried, and now you maybe get along with your stepson better than you do with your own son, and stuff like, you know, things change. Just saying. Yeah, I think I saw him.
When going for surgery, I'm kind of curious about something.
Okay.
You want to be resuscitated if you stop breathing.
Oh, yeah, well,
That isn't in this direct.
right, because, you know, now, for example, if you're having a heart attack and need an emergency bypass surgery, that's a lot more serious surgery, tenuous surgery, and that sort of thing. But if you were otherwise in decent shape before surgery, if we're going to take your gallbladder out, if something would happen, okay, in that situation, yes, we'd pull out all the stops because you would still be considered to probably have a reversible condition. So yeah, if you have an advanced directives, and we take you surgery and stop, we're not, the advanced directives is generally for chronic disease, terminal cancer, you know, situations where severe trauma, where it looks like you have a poor chance of recovery. Yes.
What percentage of us actually have a copy in our doctor's office or in its hospital?
I don't know.
Is it pretty low?
I haven't done a study. I know there's a lot more than there used to be. I think people are a lot more well versed on this than they were, say, 20 years ago. As far as a percentage, I don't. And I'm sure there are people that have some, but they just didn't take them over. You know, and with the system we have, we're on the same system as a hospital. It used to be, say, well, make sure the hospital has a copy and make sure the clinic has a copy. Well, nowadays, basically, if either entity scans one in, it's gonna have access because we're on the same, medical record system. And we can access each other's accounts, okay? But I know I don't, if I had to take a total stab at it, I would say probably between half and 2/3. I would say there's probably at least a third of people out there that probably could use one. As far as younger people, that's a lot less. Most of the people that have done that are, over age 59, 60. When you look in the mirror and your shoulders are drooping a little bit more and you got less hair than you had a couple of years ago and it's turning color and you find a few more wrinkles, you kind of start realizing, hey, there's some things that... And then if you're like me and your youngest daughter's a nurse, what's your 3-year plan? What's your 2-year plan? What's your 5-year plan? What's your, Yes. Her mother says she's like her father. So. Very good. Thank you very much.